Thank you, Jennifer and Jacob. Is there anyone here who has any questions for either of our two speakers tonight? Anything you're wondering about? So Jane asked for the low-grade tumors, um, when they're non-enhancing, what tools do you use to figure out how to resect the tumor? The extent of the tumor.
Yeah, that's a great question. The ALA doesn't work for the non-enhancing tumors. I think the Raman spectroscopy is extremely helpful because it still gives you that very rapid assessment of quantitative tumor cells. The paper that is going to come out hopefully next week, but is accepted, suggests that we should go beyond the flare. So when we use the neuronavigation in the operating room, we don't use the contrast enhancing scan, but we use the flare scan. So we should go beyond the flare, but like how far beyond is a tough question to answer. You know, the recurrences similar to glioblastoma are often at the edge of your resection cavity, so that makes you eager to resect more. But intraoperatively, it's usually a little bit is like surgeon feel. So when you're using a suction and a bipolar on white matter that's normal white matter, you have a sense for the sort of resistance of that tissue. Tumors are often woody and hard, and so you notice that it's different, and you want to get it to a portion that feels normal, looks normal on the scan, has a normal Raman value, and that's sort of, okay, we're at a super total margin. Now, it might be the case that we should be going a centimeter further if we're in a region of brain that's not going to cause a severe deficit, but we don't have any strong evidence to support that at the moment. Yeah.
I just have one question. How many people around the country are using like the Raman technique? Because it just sounds fabulous.
Yeah, not that many at the moment. It was actually developed at the University of Michigan, and the neurosurgeon there who's been heavily involved went to the New York University. So I think a handful of institutions are using it. There's also some proprietary companies that are looking at it. It was originally sort of marketed as a pseudo H&E to try to basically bypass the pathologist, so to speak, and using it at the margin of the tumor. We were the first to publish that as a viable strategy, and now we're doing a much larger study to sort of support that use. But the algorithm that determines like tumor cell quantity and density is a machine learning algorithm that's proprietary. It's not UCSF developed. It's not public knowledge. It's kind of paid for. You have to pay for it from the company. So, yeah.
So I think it's easy when patients have eloquent cortex tumors in terms of knowing that it's, location and function. But cognitive memory, you can't test that intraoperatively. So what are the efforts being made to make sure that we don't hurt our patients in that regard?
Yeah, Hugh Defoe would say you maybe could test some of it intraoperatively, but we don't do that here. I think that's a great question and important. And I'd separate it into two patient populations. I think for the glioblastoma population, we might be making this overly intimidating for a lot of surgeons out there if we're saying, well, you got to map motor, you got to map language, you got to map memory, you got to map executive functioning, you got to map cognitive control. I think for glioblastoma, our goal is to take out as much as we possibly can and not have a devastating motor and language deficit and get patients to the adjuvant therapy. Because that very first slide that showed the patients that do the best and the patients that do the worst in glioblastoma, if you don't get your adjuvant temozolomide, you do terrible. And that's probably why, and adjuvant radiation therapy. I shouldn't be neglecting our radiation colleagues, but and I think that's probably why motor deficits are so debilitating, because people go to a rehab facility, you have to delay those adjuvant therapies. For the low-grade population, we need to be doing things to protect cognition. Some of that might be actually thinking about the adjuvant therapies, and you would know better than me, but people talk about chemobrain and radiation effects on cognition. And if we do great surgeries for certain tumors, maybe we can put that off for a longer period of time. As far as mapping it in the operating room, I think there are some tasks that could be useful. And for like the mesial temporal lobe, I think we probably should be starting to incorporate things like a Stroop task or some other like short-term working memory tasks. The question is, it's always a little bit, as Jen was talking about, every patient is a little different. If you're a lawyer or someone who's got a very cognitively demanding job, you might say, hey, stop when you get to the point that you're causing a minor cognitive deficit. Other people might say quantity is more important and you should still continue to be aggressive. So yeah, the actual task that you choose, the anesthesia that you use is probably very important for being able to have patients continue to do testing. There is the sort of logistical challenges of you can't have the patient in the operating room for 12 hours while you go through every single test that you could possibly want to do. And patients get very tired. They're often in uncomfortable positions. Their head is in a frame. And so you have to be very targeted in what tasks you choose to do.
Do you see that since the DTI can tell you about the tasks or paths using imaging to help with cognition pathways?
Yeah, it might be an area where a functional MRI might have some purpose. One of Dr. Berger's Bergerisms is like functional MRI is not eloquence. And there's a lot of regions that light up if you ask someone to do a task in an fMRI region that isn't necessary for function. It might be involved in it, but it isn't necessary. I do think the one challenge with the connectome is it's based on a large standard of healthy patients. And so I don't know if it's going to map completely to the tumor patients. But I do think, I mean, it gets very complex if you start thinking about these diffuse neural networks and default mode signaling, and there's no place that's not eloquent. And that's obviously true. There's no place in the brain that's not eloquent. But for the vast majority of people, I think you can do a good surgery and not leave them in a position where they can't have a quality of life that's meaningful to them.
You just answered my question when you said there's no place in the brain that's not eloquent. Because what I was going to ask was, well, if you're trying to preserve language and motor skill and cognition and executive function, how much of the brain is actually free to be lost without impact?
Yeah, I mean, I'm a simple surgeon, and so like people will act very normal if you take out the entire right frontal lobe, the entire thing. I could do it to anyone in this room and no one would know. But if you put them through extensive cognitive testing, they might be a little bit slower on a working memory task. But the only person that's going to care about that is if someone is like a waitress or a waiter and they have to memorize 5 orders at a table and it's really critical to their job. So there's no part of the brain that's non-eloquent, but as surgeons, there's a lot of parts of the brain that are not eloquent, if that makes sense. Yeah.
One of the things that I used to be approached with a little bit hard, like, oh, if you're going to get a tumor, get in the right frontal lobe. It's the most forgiving. And I have seen all over the map people with occipital tumors. Like some people are like, oh, it's just a feel good, it's completely annoying. And some people are like, I cannot function because I have to turn my head to look at things. Okay, that's for you, that's too much, you know. But if somebody's makes their living driving a truck, then they have a field cut and it's in a blind spot, they can't drive safely, and then it is devastating. You know, it really matters knowing the patient, knowing what they can tolerate. And for me, like, also knowing, like, how to kindly tell a patient that an uncontrolled disease is going to give you these same deficits.
Yeah, that's a great point.
It's really difficult to say that to people.
Yeah, like if they're having chronic seizures from the tumor, that's probably more debilitating than the minor cognitive deficit that could be associated. Or if they have uncontrolled tumor progression, you know, we as surgeons don't like to feel responsible for causing these deficits, but sometimes you're in a little bit of a rock and a hard place. You have to do something.
Great.
Thank you so much. And I just want to end tonight just thanking Adam and his family for making this opportunity possible. We're really grateful that we can be here to do this in his honor.